Hello everyone again. My name is Fay Pilafian. I'm part of the collaborative team, physiotherapy team of Dr. Antonogiannakis. Our approach is based on the doctor-physiotherapist relationship, a comprehensive approach to improve the treatment and outcomes for our patients. The surgery is primarily concerned with correcting the anatomy, whilst the primary concern for the physiotherapist is the restoration of function. Both professionals would aim to minimize the risk of an injury reoccurring through regular feedback. When the patient decides that the surgical treatment fits better with him, he visits the clinic. During this appointment, and in collaboration with the doctors, an evidence-based approach to assessment is presented. The physical examination, the test, scores, questionnaires, range of motion, VAS scaling, coordination, and more. As we already said, the patient is 53 years old, male, working with computers in office. What I actually want to mention, because we already said, is that he has hypermobile shoulders, while his dominant hand has an external rotation with abduction 130. We make sure the patient understands the pathology of the unstable shoulder and the function of the stabilizers, static and dynamic. We provide instructions about looking after the shoulder after the patient is discharged from hospital, how he's going to change his clothes, how to apply the sling, his sleeping position, do his hygiene, and all the activities of daily living. We aim for robust and clear communication in order to inspire the patient and extend the effects of our treatment, at least during the first few weeks. In case the patient, for any reason, decides to follow a rehabilitation program outside of our physiotherapy team, for example, in a physiotherapy center, we set follow-ups at 6 weeks, 3, 6, 9, and 12 months. In our case, the patient followed his post-surgery treatment within our physiotherapy team. The surgery was performed by Dr. Antonogiannakis and his team on the 9th of November 2020. The purpose was to augment the glenoid bone surface, reinforce the anterior capsule, restore the injury of the anterior labrum. The surgery was an arthroscopic modified head bone block procedure, which is an arthroscopic anteroinferior shoulder stabilization technique with an iliac crest cortical bone graft using buttons. Also associated with arthroscopic subscapularis augmentation for, arthroscopic subscapularis augmentation for treating glenohumeral instability with glenoid bone loss, and capsulolabral reconstruction, the anterior capsulolabral deficiency to reduce its volume and deepen the glenoid socket along the glenoid bone. We encourage patients to follow a home exercise rehabilitation program. One session of 1 or maybe 1.5 hours per week, and its success relies on patients' compliance. In these sessions, we educate the patient to help identify the signs within their body, such as pain, tenderness, weakness. We explain the recovery steps so the patient understands when he can adjust repetitions, load, contraction speed. We incorporate the patient's goals, which helps them to stay motivated to perform his exercise routine, and we identify and address any biophysiological elements that may impair the patient's recovery in order to achieve a successful treatment outcome. The rehabilitation program was focused on scapular dyskinesis, restoration of scapular position and movement pattern, the kinetic chain, shoulder muscles co-contraction, dynamic shoulder stabilization, and of course, re-education of the sensory motor system, proprioceptive information, and neuromuscular control. With these strategies, we achieve the following functional results. Coordinating scapula and glenohumeral muscles activation. Co-contraction of antagonistic muscles and the timing of recruitment. The rehabilitation process achieved range of motion recovery without disturbing the bone graft area, promoting its integration through delayed external rotation in abduction position. Also, gentle but not stressed activation of subscapularis muscle, avoiding stress to the healing anterior capsuloligamentous structures by gaining delayed external rotation in neutral, even if that means below 0 until the third postoperative month. And the process also achieved restoration of functional stability by motor learning through the activity of the dynamic stabilizers mediated by the sensory motor system with closed and open kinetic chain exercises, rhythmic stabilization, movement on stable and unstable surfaces, and plyometric activation exercises. For the first 6 weeks, the patient's external rotation was below 0. By the third month, he had external rotation in neutral 20 degrees and with abduction at 80 degrees almost, around 30. Around month 5, appointments with the patient were decreased to once a fortnight. By month 6, the patient achieved a significant increase in external rotation, which was in neutral and with 90 degrees abduction around 80 degrees. And the strength was 8 kilograms when the right one, which is the dominant, was 11 kilograms. He had the ASA score almost 92 and Oxford scores 43 from 48. After 6 months, he was able to undertake most activities. He was able to prior to operation. He used to enjoy calisthenic workouts, and we managed into that time frame to perform similar activities. And this is after the 6 month. What we need is to be functional, not to be like the other shoulder. In conclusion, we want to emphasize the importance of the doctor and physiotherapist collaboration. The rehabilitation program is ultimately guided by the technique and strategy adopted by the surgeon in the operation room. The physiotherapist, following the purpose steps, optimizes the final functional result. Also, in cooperation with the surgeon, it's important to be aware and in contact at all times in order to optimize the patient's recovery, as every patient is unique and every plan is custom created based on each patient's needs. Thank you.